Good day, everyone. Today we will discuss something that's in the news, Nipah virus infection. We will answer a couple of questions, with the first being, paano ba nahahawa sa Nipah? Is it really a new threat? Also, panic time na naman ba? Paniki, tama na. Nipah virus infection is a highly pathogenic zoonotic disease that continues to cause outbreaks in South and Southeast Asia and remains on the priority pathogen list of the World Health Organization. Nipah virus, or NIV, is a bat-borne paramyxovirus with high case fatality rates, typically 40 to 75%. That's high. There's also documented human-to-human transmission. There is presently no licensed vaccine and no approved specific antiviral therapy. Although outbreaks are usually limited in size, Nipah has three characteristics that make it clinically and epidemiologically important. Number one, it has high mortality. Number two, there's nosocomial amplification potential. And number three, there is some pandemic concern due to possible viral evolution. Today's lecture will cover the following. Number one, epidemiology, modes of transmission, recent outbreak updates, clinical features of Nipah virus infection, how it is diagnosed, how it is treated and managed, and lastly, infection prevention and control. Nipah virus was first identified in 1998 during an outbreak among pig farmers in Malaysia, in the village of Sungai Nipah, located in the state of Negeri Sembilan. The natural reservoir is fruit bats of the genus Pteropus, also known as flying foxes. These bats, and you can see them in the figure, shed virus in saliva, urine, and partially eaten fruit. So you can see them there in the photo, hovering around the tree, going to the fruits, trying to eat at the fruits, and in the process they introduce the virus to the fruit itself. The bats also have wide geographic distribution across South Asia and Southeast Asia, as we shall see in the next slide. Human outbreaks have been reported in Malaysia, Singapore, and lately in the news, Bangladesh and India. The Philippines had a 2014 outbreak involving contact with infected horses and possible human-to-human transmission. Bangladesh and India have the most consistent seasonal outbreaks. The case fatality rate ranges from 40 to 75%, depending on healthcare access, strain variation, there's a difference between the Malaysia and the Bangladesh strains, and speed of supportive care. The Bangladesh strain is both more lethal and more likely to spread between people compared to the Malaysia strain. The Philippine strain of Nipah virus, identified during the 2014 outbreak, had an estimated case fatality rate, or CFR, of about 53%. There were 17 laboratory confirmed and probable human cases, and total deaths were 9. For context, transmission involved contact with infected horses and possible human-to-human transmission. The mortality rate was higher than the Malaysia outbreak, which had a 40% CFR, but this was generally lower than many of the Bangladesh outbreaks, which had 70% or higher case fatality rates. Genetic analysis showed that the Philippine strain is distinct but more closely related to the Malaysia strain than to the Bangladesh strain. From recent systematic review data, the estimated R0, or the basic reproduction number, of Nipah virus is 0.33, so less than 1. This means that sustained epidemic spread is unlikely under current conditions. Just to provide a comparison, the original or ancestral SARS-CoV-2 the virus that caused COVID, had an R naught of around 3. And this was considered transmissible, very transmissible already. So as you can see, Nipah virus is not as transmissible, while the original ancestral SARS-CoV-2 was transmissible, while Alpha variant was even worse at 4.5. Delta was even much more transmissible since its reproduction number was 5. And Omicron, though it had many subvariants, had the worst at almost 10 R naught. However, outbreaks are driven also by super spreading events. Approximately 70% of human-to-human transmission cases were linked to a small minority of index cases. Now this tells us something critical. Nipah does not spread easily, but when it does, it can spread explosively in clusters. Now we go to modes of transmission. Transmission occurs in 3 main ways. The first one is zoonotic transmission. Look at the bats in the figure. First is contact with infected bats. Of course, they have the virus, and if a person, comes in close contact with the bat, they can get infected. Second is consumption of raw date palm sap. And you see also in the figure, the bats on the left side are hovering around the date palms, right? And in the process, they can contaminate the date palm, including the sap, the liquid. And this can, if you see in the figure, the people collect the fluid, the sap, and of course sometimes they sell it, sometimes they give it to their family members or friends, and they may become contaminated also, and therefore infected by the Nipah virus. And then third, contact with infected animals such as pigs and horses. If you look at the middle, the middle tree, there are a lot of bats also there, hovering around. And these bats are trying to eat away or eat at the fruits. So that contaminates the fruits with the virus. And when they fall to the ground, the pigs and or the horses eat off the fruit. And what happens is the pigs and the horses get infected with the virus. And when the humans come in contact or get close to the pigs and or the horses, the humans can get infected as well. And this includes, eating of the meat of the pigs and the horses. So humans can also get infected via that route. In Bangladesh, as we mentioned earlier, drinking fresh date palm sap is a major risk factor. Second, human-to-human transmission. The documented routes include, number 1, direct physical contact from infected humans to another human. Number 2, exposure to respiratory secretions of those humans who are already sick with the Nipah virus. And number 3, contact with body fluids. Any body fluid may contain the virus and may infect the second or third or the next human. And then last, being in the same room for prolonged periods. Now remember, of course, the secretions, and then of course the respiratory droplets may also contain the virus. And being in the same room, increases the chances that human-to-human transmission may occur. Now, meta-analysis shows that close contact with Nipah virus or a Nipah virus case increases infection odds by nearly 7-fold. And then number 3, nosocomial transmission. Hospital transmission is a major concern. Nearly half of human-to-human transmission events in Bangladesh and India were nosocomial. Now, the risk factors include delayed diagnosis, overcrowding, poor ventilation, inadequate PPE or personal protective equipment, and then family caregivers without training. This is why Nipah is as much an infection control challenge as it is a clinical disease. Recent reports from the World Health Organization highlights continued seasonal spillovers. In Bangladesh, just this year, a fatal laboratory-confirmed case linked to raw date palm sap consumption was reported in Rajshahi Division. 35 contacts were monitored. There were no secondary cases detected. Risk assessed was low. This was nationally and globally, which was good. And in India, also this year in West Bengal, 2 confirmed cases were both healthcare workers. And what was done? Immediate isolation, aggressive contact tracing was done also, and there was no documented sustained transmission. Again, just showing the fact that this is really not a very transmissible disease when there are apt precautions that are done. International coverage emphasized global concern, but WHO maintained that it was of low pandemic risk. The key takeaway is that outbreaks continue to occur annually, but rapid public health response limits the spread. So before we go to the clinical features, let's first discuss its incubation period. Typically, it's 3 to 14 days, although occasionally longer. So what's incubation period again? Incubation period is the time that it takes for symptoms to occur after the virus is able to penetrate into the body. So a patient, after the virus gets inside, the virus will take time, and that's the incubation period, before the patient, before the virus is able to, reproduce in such a significant amount that the patient starts having symptoms. And the early symptoms are as follows: fever, headache, muscle aches or myalgia, vomiting, even sore throat. Respiratory features are also possible, especially with the Bangladesh strain. That means one can get cough, shortness of breath, even pneumonia, and the non-cardiogenic or non-heart-related pulmonary edema or acute respiratory distress syndrome, which is also life-threatening. Neurologic features are also possible, especially since Nipah is primarily a neurotropic virus, meaning it loves, going to and invading the nervous system. And that may cause altered mental status, confusion, seizures, encephalitis, and even rapid progression to coma. Now, physical examination findings can include fever, reduced Glasgow Coma Scale, or the sensorium of the patient will go down. The head will not be clear. Consciousness may be affected. Neck stiffness may also occur occasionally. Focal neurologic deficits, and even, as we mentioned earlier, signs of respiratory distress. Now, for laboratory findings, the common abnormalities look viral, since it is a virus. So low platelets or thrombocytopenia, low white blood cell count or leukopenia, elevated liver enzymes, specifically ALT and AST, some mild kidney or renal impairment. And for those who have neurologic features that, of course, when lumbar puncture is done and the spinal fluid is examined, there is a predominance of lymphocytes or lymphocytic pleocytosis and elevated protein in the cerebrospinal fluid. Now, imaging studies, especially for those who have, who have neurologic symptoms, and the MRI of the brain will often show multifocal cortical lesions, brainstem involvement, or leptomeningeal enhancement, so signs of meningitis on imaging. And the late complications may develop, although some survivors, those who are able to survive and get over the bad types of features of this disease, may have relapse encephalitis weeks to months later, or chronic neurologic deficits, even neuropsychiatric sequelae. This makes long-term follow-up very important. Now, for diagnosis, we start with clinical diagnosis. We should suspect Nipah in a patient with acute encephalitis syndrome, severe respiratory illness, But of course, connect that with relevant exposure history. That is why asking about, travel, activities, as we mentioned, exposure to pigs, horses, trees, in areas where, there may be bats, okay, fruits that may have fallen, onto the to the ground, and the patient may have eaten that. Contaminated meat, from those animals that could have been contaminated and infected with Nipah virus. So relevant exposure history is very important, especially at this stage when there is really no sustained transmission. At this stage, relevant exposure history is very important to connect to the acute encephalitis syndrome and to severe respiratory illness. And of course, especially in an area where there's an ongoing outbreak setting, of course, that one is a very important piece of information that you need to be on the lookout for. Now, for laboratory diagnosis, the gold standard is RT-PCR from either blood, respiratory samples, or CSF if lumbar puncture is done. In other countries, serology, IgM and IgG, these are antibodies, can be tested. Of course, viral isolation can be done, but this requires a biosafety level 4 lab that is rarely used clinically. What is important though is the specimen handling, and it must follow strict biosafety protocols. Now, for treatment and management, there is no licensed antiviral therapy. And if we remember, during the COVID pandemic, initially that is also what happened. There was no licensed antiviral therapy. And that is the case right now for Nipah virus. So management is supportive. And supportive care includes airway management for those who have difficulty breathing, oxygen supplementation as well, and mechanical ventilation for those in acute respiratory distress syndrome or acute respiratory failure. Seizure control for those who have seizures, if the CNS, central nervous system, is affected. Of course, fluid and electrolyte balance, and then management of intracranial pressure also in those with neurologic problems. Of course, early ICU level care improves survival. Now, let's just go a little bit on the investigational therapies. These are the ones that are not yet, there's no good evidence yet. So remdesivir, which we used for COVID, it was effective in animal models. Favipiravir, we also used that for COVID. There is some animal data. Monoclonal antibody M102.4 is promising but not yet licensed. Ribavirin has limited and inconsistent evidence. So again, there is no approved vaccine currently available. Thus, survival depends heavily on, number one, early recognition, and that's why the first part of this lecture is very important. Aggressive supportive care and strict infection control, which is the next part of the lecture. Now we go to infection prevention and control. This is arguably the most important section. First, we go to hospital IPC. So in hospitals, we need standard precaution plus droplet and contact precautions for all suspected cases. In fact, airborne precautions are needed for those who will have or undergo aerosol generating procedures. So the key measures for IPC, or infection prevention and control, are putting patients in a single isolation room ideally, using an N95 respirator, especially at the start, when we don't know yet if it is Nipah or if it's something else. Eye protection, gown and gloves, strict hand hygiene, environmental cleaning, and restricted visitors. And like I said, at the start, you don't know yet if it's Nipah or something else, and therefore it's reasonable to do airborne precautions first. But down the line, if it is confirmed that it's Nipah, then you can downgrade to droplet precautions. So healthcare workers must be trained, and super spreading events are typically hospital-based, and therefore IPC is very important to prevent those from occurring. Now, community IPC hopes to prevent spillover. No? And what are the things that can be done? Avoiding raw date palm sap, washing fruits thoroughly, avoiding contact with sick animals, or eating fruits that have fallen to the ground, right? And of course, public education campaigns. Now, during outbreaks, there should be rapid contact tracing and active symptom monitoring, and lastly, safe burial practices. WHO currently does not recommend travel bans during outbreaks. Now, final take-home messages. Number 1, Nipah virus is rare but deadly. It spreads primarily through close contact. Super spreading drives outbreaks. Clinical presentation often includes encephalitis and respiratory failure. Diagnosis relies on RT-PCR. Treatment is supportive, and infection prevention is the most powerful control tool. If recognized early and IPC is strictly implemented, outbreaks can be contained. Let me end with something poetic but still rooted in what we talked about. This is entitled, Meron na naman ba? Nipah, wala pa. Ang Nipah virus unang nakita noong bago natapos itong dantaon. Nadiskubre siya ng mga taga doon sa Malaysia at Singapore pa. Malubhang sakit, kuha sa baboy, ito ay delic na kamamatay. Pero nagmula sa paniking sa puno'y sumadya at kinain niya ang mga prutas, nahulag naman sa baba sa grass at nilapitan ng kabayo o baboy na gutom, prutas, mikrobyo, mga nilamon. Sa hayop naman, pwede makuha ng taong bayan, pwede manghawa. Utak at baga, tinatamaan. Sa Bangladesh, India ay taon-taon. Sa Pilipinas, 2014, huling lumipas. Salamat sa Diyos. Simula noon, wala nang bago. Sa India, meron. Bawal ka dito. So thank you very much. Keep safe, everyone.